My name is Gunjan Aggarwal, and I'm talking today about novel oral anticoagulants in patients with atrial fibrillation. I'm using PowerPoint for my talk today, and these slides are available for you to download from our website. Patients with atrial fibrillation are at high risk of stroke. It's important to bear in mind that irrespective of the type of atrial fibrillation, whether it's paroxysmal or persistent or permanent, the risk of stroke is the same. So it doesn't matter what type of atrial fibrillation it is. Now, it's also important to bear in mind that stroke in patients with atrial fibrillation is often more severe, it's more likely to be severely disabling, and the risk of death is often doubled. Now, the majority of AF-related strokes are ischemic strokes, and we know that antithrombotic therapy with warfarin or with one of the novel oral anticoagulants reduces the risk of stroke by up to 65%. So really only antithrombotic therapy has been shown to reduce mortality in patients with atrial fibrillation. So obviously in a primary care setting, it is of utmost importance that when you see a patient that you discuss with them the risks of them experiencing a stroke and balance that against the risk of bleeding, and taking into account patient preferences, then make an informed decision about anticoagulation. So this image is a two-dimensional transesophageal echocardiogram that's been performed in a patient prior to electrical DC cardioversion. As you can see, the image on the left, there is a echo density in the left atrial appendage, and this is essentially left atrial thrombus. So without appropriate anticoagulation, there is a very high risk that this thrombus can embolize and either cause a stroke or a systemic embolism. So this is a very exciting era for us as physicians, because in the last few years there's been very exciting developments in the field of anticoagulation. Up till now we've only really had warfarin therapy, and in the last 3 years there's been 3 new drugs that have become available. Now we know that warfarin effectively reduces the risk of stroke by up to 64%. We also know that despite this, up to 50% of candidates that would be suitable for anticoagulation in patients with atrial fibrillation don't actually receive appropriate treatment. And so there's a lot of barriers for this underuse of warfarin, and this can vary from things like the need for regular INR monitoring, which can be problematic in certain patients. Certain patients often refuse to take warfarin because of the perceived risk of intracranial bleeding. There's a challenge in maintaining INR levels, especially with the myriad of dietary interactions that patients have to encounter. And so all in all, with all these risks of drug interactions, the contraindications, dietary restrictions, warfarin has been underused in the past. The commonly used risk stratification tool for patients with atrial fibrillation has been the CHAD score. More recently, the CHAD score has been updated and replaced by the CHADS-VAS score. And the main benefit of the CHADS-VAS score is that it offers more exquisite risk stratification, especially for the lowest scores. The main difference between CHADS-VAS and CHADS score is the addition of 3 new categories. So you score 1 point for the presence of peripheral vascular disease or coronary artery disease. You score 1 point for age more than 65. Age more than 75 now constitutes 2 points, and being female constitutes 1 point. So whenever you see a patient with atrial fibrillation, it's important to calculate their CHADS-VAS score, and then depending upon the total score, then appropriate decisions can be made about anticoagulation therapy. This slide shows the annual risk of stroke for patients with different CHADS-VAS scores. As you can see, on the vertical axis is the yearly risk of stroke, and on the horizontal axis is the CHADS-VAS score. So there appears to be a linear relationship between the risk of stroke and the CHADS-VAS score. As the CHADS-VAS score gets higher, there is a progressive increase in the risk of stroke. So for high scores up to 5 or 6, the risk can be as high as 13 to 15%. The risk of stroke needs to be balanced against the risk of bleeding in every patient with atrial fibrillation. There is a tool that's available called the HAS-BLED score, and this provides different points for risk categories, including hypertension, abnormal renal function, stroke, and the use of concurrent drugs. So it is recommended that you assess the risk of bleeding for every individual patient using the HAS-BLED score. This can be useful in certain settings where you may wish to address risk factors such as hypertension, for instance, or concomitant antiplatelet therapy, and thus reduce the HAS-BLED score. However, this should only be used as a tool and should not be used to omit anticoagulation therapy for patients that are appropriate for it. One of the most feared complications with warfarin therapy is intracranial bleeding, and certainly this is disastrous when it does occur. And there are quite a few risk factors for this, including age more than 60, uncontrolled hypertension, and previous intracranial hemorrhage. So this table allows you to decide how to use anticoagulant therapy and in what situations. So if you have a patient with atrial fibrillation, it's important to assess if they have valvular atrial fibrillation. So if there is rheumatic mitral stenosis or hypertrophic cardiomyopathy, then generally warfarin therapy is recommended, and novel oral anticoagulants are contraindicated. So if they don't have valvular atrial fibrillation, then based on the age and their CHA2DS2-VASc score, depending upon what the score is, recommendations can be made about anticoagulation therapy or no anticoagulation therapy. Generally, for a score of 0, antithrombotic therapy is not recommended. For a score greater than or equal to 2, oral anticoagulant therapy is recommended, and either warfarin or one of the novel oral anticoagulants can be used depending upon patient preferences. For a score of 1, the European guidelines advocate that we should use anticoagulation therapy, although the American guidelines state that either aspirin or warfarin or novel oral anticoagulant therapy may be used depending upon physician and patient preference. So the 3 new novel oral anticoagulants all work differently. You have the thrombin inhibitors such as dabigatran, which work slightly differently from rivaroxaban and apixaban that are factor 10 inhibitors. The main difference between warfarin and novel oral anticoagulants is summarized in this slide. The onset of warfarin, as you know, is fairly slow, whereas the new agents offer a very rapid onset of action. The dosing in warfarin is clearly variable depending upon the INR, whereas the new agents have a fixed dosing. The other main benefit of the new drugs is that there's no dietary interactions with green vegetables, which is one of the problems associated with warfarin. Also, there are fewer interactions with the new drugs, and they're predominantly with cytochrome 2A4 and P-glycoprotein drugs, whereas warfarin has numerous interactions. Also, there's no need for monitoring with the novel oral anticoagulants, whereas warfarin requires INR monitoring. Also, the offset of action is fairly long for warfarin, whereas it's a lot shorter for the new drugs. The novel oral anticoagulants do offer substantial benefits compared to warfarin therapy, and some of these benefits include the rapid onset of action and offset of action, and fixed dosing. As you know, warfarin requires variable dosing and the need for frequent INRs, which can be problematic in certain patients. One of the other big advantages is that there is no dietary interactions that are often observed with warfarin therapy. And perhaps the greatest advantage is the lack of need for regular monitoring with the new drugs, as is usually the case with warfarin with INR levels. The pharmacology of the 3 novel oral anticoagulants is slightly different, and it's important to know of the subtle differences that do exist. Dabigatran is a prodrug, whereas apixaban and rivaroxaban are not prodrugs. The doses of all 3 drugs are slightly different, and they need to be adjusted depending upon the risk of bleeding and renal function. Dabigatran is the only drug that's predominantly renally excreted at up to 85%, whereas the other 2 drugs are 30% renally excreted. The mean half-life of all 3 drugs is similar at around 12 to 13 hours, and the time to peak effect is also similar, on average around 3 hours. Looking at apixaban, the landmark trial that assessed the benefit of apixaban was the Aristotle trial, and this trial showed that apixaban was more effective than warfarin in terms of the risk of bleeding. It also was more effective in terms of reducing the risk of hemorrhagic stroke, intracranial bleeding, and a composite of stroke and systemic embolism. The trial that looked at dabigatran was the RELY trial, and I will cover the lower dose of 110 milligrams first. So when the lower dose of 110 milligrams was compared with warfarin, there was no difference in terms of the risk of stroke and systemic embolism. However, there was a lower risk of major bleeding compared to warfarin. In contrast, the higher dose of dabigatran at 150 milligrams BD was more effective than warfarin when we looked at a composite of stroke and systemic embolism. However, this was at a cost of more GI bleeding. It was non-inferior to warfarin when it came to the risk of major bleeding. The landmark trial for rivaroxaban was ROCKET-AF, and when you compare rivaroxaban to warfarin, it was non-inferior to warfarin when it came to a composite of stroke and systemic embolism. The risk of major bleeding was similar to warfarin, with a trend towards more GI bleeding. It would be useful to directly compare all three drugs and look at their individual benefits in terms of risk of stroke and risk of bleeding, as this information helps us make a decision about which drug may be appropriate in certain clinical settings. So when we look at the composite of stroke or systemic embolism, all three drugs were superior to warfarin. When we look at ischemic stroke, dabigatran and rivaroxaban were superior to warfarin when it comes to stroke prevention, and apixaban was similar. When it comes to the risk of hemorrhagic stroke, all three drugs are significantly superior to warfarin. Moving on to the risk of bleeding, when we look at intracranial bleeding, the novel oral anticoagulants offer substantial benefits compared to warfarin, as they all reduce the risk of intracranial bleeding. When we look at major bleeding, the only drug that reduces the risk of that compared to warfarin is apixaban, and this is perhaps a key feature that helps differentiate apixaban from the other two drugs. When you look at dabigatran and rivaroxaban, the risk of major bleeding was similar to warfarin. When it comes to gastrointestinal bleeding especially, both dabigatran and rivaroxaban actually increase the risk of GI bleeding compared to warfarin, whereas apixaban, there's a trend towards lower GI bleeding compared with warfarin. So this is perhaps another differentiating factor when it comes to apixaban and the other novel oral anticoagulants. So it would be useful for us to summarize the key findings with all three novel oral anticoagulants. All three drugs are at least non-inferior or superior to warfarin when it comes to a composite of stroke and systemic embolism, with rivaroxaban being non-inferior and the other two drugs being superior to warfarin. When it comes to hemorrhagic stroke, which is a disastrous complication with warfarin therapy, we know that all three drugs substantially reduce the risk of that happening, up to 75%. However, when it comes to major bleeding, apixaban is the only drug that's been shown to cause a 30% reduction in the rates of major bleeding compared to warfarin, whereas the other two drugs are similar to warfarin. The European guidelines recommend that in patients where warfarin is causing significant problems, whether it comes to monitoring INR levels, or if patients are experiencing side effects, or if they're having difficulties undertaking INR monitoring, then it would be reasonable to switch them over to one of the novel oral anticoagulants, provided there are no contraindications. And this carries a Class 1 recommendation. When the novel oral anticoagulants are considered, any one of the three agents can be used depending upon the clinical characteristics of the patient. The absorption and metabolism of the three drugs are slightly different. Rivaroxaban and apixaban are not prodrugs, whereas dabigatran is a prodrug. The other important difference is that it's mandatory that rivaroxaban be taken with food, whereas the other two drugs don't necessarily need to be taken with food. Also, up to 10% of patients who take dabigatran therapy can experience side effects of dyspepsia, which is not a recognized side effect with the other two drugs. It's important to bear in mind that patients with mechanical heart valves are not candidates for novel oral anticoagulants. This is based on a landmark trial where the trial was terminated early because of excess mortality when the novel oral anticoagulants were used compared to warfarin. So at present, the guidelines state that in patients with mechanical heart valves, warfarin therapy should be used. The novel oral anticoagulants are contraindicated in pregnant women, in patients that have a creatinine clearance of less than 30 mL per minute, or if they've had a hemorrhagic stroke in the last 12 months. Other contraindications include if they've had active bleeding, especially gastrointestinal bleeding, within the last 12 months where the cause has not been adequately treated. The PBS Streamline Authority Code for these new drugs is 4269. The preferred method for assessing creatinine clearance is Cockcroft Gold, and there are calculators that are available online that allow you to determine this information. You need to key in characteristics such as serum creatinine, age, sex, and weight of the patient, and this allows you to determine the creatinine clearance in mils per minute. It is preferable that this is used rather than a EGFR, as creatinine clearance using Cockcroft Gold is more accurate. The dose of dabigatran is usually 150 milligrams BD, although the lower dose of 110 milligrams should be used in certain scenarios. The main ones are elderly patients over the age of 75, where the higher dose has been shown to produce excess gastrointestinal bleeding. It has been my practice to avoid dabigatran for patients more than the age of 80 because of the higher risk of bleeding. It's also important to determine the overall risk of bleeding, and for patients with a high risk of bleeding, a lower dose of 110 milligrams BD can be used. Also, patients with moderate renal impairment, so calculated creatinine clearance of 30 to 50 mL per minute, a dose of 110 milligrams BD is the preferred strategy. When it comes to rivaroxaban, the usual dose is 20 milligrams daily, although the lower dose of 15 milligrams daily should be used in patients with moderate renal impairment, so that's a calculated creatinine clearance of 30 to 50 mL per minute, or when the bleeding risk is considered to be excessively high. For apixaban, the usual dose is 5 milligrams BD, although a lower dose of 2.5 milligrams BD can be used if 2 out of 3 clinical criteria are fulfilled, and these being age more than 80, weight less than 60, or creatinine more than 133. It is also recommended that a renal function and a hemoglobin level is performed at least 2 to 3 times a year on the novel oral anticoagulants to assess whether dose adjustments are required depending upon subsequent renal function. It is very important to note that all 3 drugs are contraindicated in patients with a creatinine clearance of less than 30 mL per minute. It's important to think very carefully about whether warfarin therapy or novel oral anticoagulant therapy is most effective depending upon the clinical characteristics of the patient. As I've discussed earlier, patients with mechanical heart valves or valvular atrial fibrillation are candidates for warfarin therapy, as novel oral anticoagulants are contraindicated in these settings. It's important to bear in mind that patients with significant liver dysfunction who have an elevated INR are also not candidates for novel oral anticoagulants, and warfarin therapy is appropriate in these patients. Patients who are prescribed the novel oral anticoagulants, it is extremely important that when prescribing this drug that discussions are had about the need for adherence to therapy. Because of their shorter onset and offset of action and short half-lives, these drugs can be unforgiving if more than 1 or 2 doses are missed, and the risk of stroke can be high in that situation. That's obviously not the case with warfarin because of its slower onset of action. So perhaps patients that are poorly compliant, it may be prudent to use warfarin in favor of one of the novel oral anticoagulants. If patients are stable on long-term warfarin therapy, it is reasonable to continue warfarin, especially if the patient does not indicate a preference to change to one of the newer drugs. A small percentage of patients with dabigatran therapy do experience dyspepsia and other upper gastrointestinal symptoms, so it would be appropriate to use either rivaroxaban or apixaban in this category of patients. When it comes to bleeding profile, apixaban offers a lower risk of major bleeding and gastrointestinal bleeding, and this is perhaps a differentiating characteristic. So patients that are considered to be at high risk of gastrointestinal bleeding, perhaps apixaban would be the drug of choice in favor of the other two drugs. When it comes to the greatest effectiveness in preventing ischemic stroke, so for instance, in patients that have an ischemic stroke on warfarin therapy, dabigatran at a dose of 150 milligrams BD provides the strongest benefit, and so this should be used in those particular subgroup of patients. If patients indicate a preference for a once daily dosing regimen, then rivaroxaban would be the appropriate drug, as the other two drugs are taken twice daily. Finally, if the patient has had a recent acute coronary syndrome, then given the early data of a possible higher signal for acute coronary syndrome with dabigatran, it is best that dabigatran is avoided in these patients until further information is available. It is a common clinical scenario for patients on novel oral anticoagulants to stop therapy due to concurrent surgical procedures. The duration for which time the drug has to be stopped depends upon whether it's a low risk or a high risk procedure. So for high risk procedures such as thoracic or abdominal or major orthopedic surgery, it is recommended that the drug is stopped for at least 48 hours, although this may need to be prolonged to 72 hours depending upon the renal function of the patient. For procedures that are considered low bleeding risk, such as endoscopy, biopsies or electrophysiological procedures, it's recommended that the drug be stopped for a minimum of 24 hours prior to the procedure. There is a checklist that should be followed during follow-up of patients that have been started on the novel oral anticoagulants. GPs are in a very good position to be able to ensure that the patient is compliant with the drug and has not experienced any further episodes of thromboembolism. It's also important during follow-up visits to assess whether there's been any episodes of bleeding or other side effects which may be of relevance. It's also important to obtain a drug history to make sure that there's no over-the-counter drugs or new prescription drugs that have been started which may have an interaction with the new drugs. Finally, it's also recommended that GPs perform blood sampling on at least a 6-monthly basis, checking the patient's hemoglobin and renal function, as this often has the potential to alter patient management. On a final note, when it comes to success in treating your patients with atrial fibrillation, it's important to not disregard certain clinical issues which are of utmost importance when it comes to successfully treating patients with atrial fibrillation. And these are excessive alcohol intake, obesity, obstructive sleep apnea, and hypertension. And if you treat these 4 conditions well, then you're likely to have a great deal more success when it comes to treating patients with atrial fibrillation. I'd like to thank you for giving me this opportunity to talk to you today, and I hope this talk has been of benefit to you. If you are interested in downloading our slides, they are available on our website.